This is Alessandro Fiocchi, Director of Allergy at the Pediatric Hospital Bambino Gesu in Rome. Today we will share the data produced by our group in children allergic to foods with severe asthma. This is an observational study indicating the effects of omalizumab in such children. Today, a patient with food allergies do have practically two options. The first is avoiding foods that may be easy in some cases and not such in other cases. The second is to go for an oral immunotherapy. This may raise the threshold of reactivity, but is time resource consuming and may expose to side effects. Thus, while avoidance may be a sort of hell in some cases, oral immunotherapy is better, but may be a sort of purgatory in other cases. This explains why earlier this year, when American colleagues published data indicating that omalizumab is able to substantially raise the threshold of reactivity to peanut, cashew, egg, milk, walnut, wheat in a cohort of children allergic to foods, the enthusiasm are aroused not only in the allergy community, but also in the general public. The New York Times dedicated an article to that, indicated that for the first time a drug is able to drastically reduce the children's reactions to food allergens. However, this study did not address the effect of omalizumab on the reduction of anaphylaxis episodes, nor was able to show that omalizumab increases the quality of life of the patients and their families. Thus, the FDA approval for the use of omalizumab in food allergy indicated that children and patients allergic to foods should go on with avoidance of risky foods while on omalizumab. Our study offers some observational response to the question if omalizumab is able to reintroduce allergenic foods to patients. First of all, we confirmed that omalizumab is able to multiply the tolerance threshold for foods in children. This multiplication was 250 times for raw milk, 500 times for baked milk, 170 for raw egg, and so on. So this was really substantial. But we also were able to indicate that from 100 reactions to foods in the previous year, children experience less than 10 reactions to foods in the following year while under omalizumab, and that this translates in an increase, in a normalization of quality of life for the families and for the patients, thus making omalizumab a possible third way for the treatment of food allergy. What's also interesting is that our data indicate that children allergic to foods are able to introduce them in 88% of cases without any oral immunotherapy maneuver, thus indicating that the increasing of thresholds may actually translate in a successful reintroduction of foods. While our evidence is observational, this offers answer to several questions. Is omalizumab able to reduce the anaphylactic episodes? Yes, it is. To restore patients' and parents' quality of life? Yes. To allow the introduction of foods, and in particular of foods labeled with precautionary allergen labeling? The answer is again yes. If such results will be confirmed, then omalizumab may offer a third way for food allergy sufferers, a way that maybe is better than the hell and the purgatory of avoidance and oral immunotherapy. Maybe it will be a paradise. Thank you for your attention.